Good morning. My name is Michelle Moss. I'm the STEMI and Trauma System Manager for Sierra Sacramento Valley EMS Agency. I was asked to talk today about our STEMI system and how we use our EMS and hospital data to inform our quality improvement process and to strategically focus our efforts on the challenges that may be unique to our region and to our system structure. I'll talk briefly about our STEMI program and how we built our team and established a strong foundation with commitment from all of our stakeholders. I'll touch on our decision to move from an Excel spreadsheet for data collection to a full-featured registry and some of the challenges and opportunities that came along with that decision. And then lastly, I'll talk about how we established our metrics and how we use all of this data for QI and system improvement. So back in 2009, SSV hired its first STEMI program manager. He was tasked with building our regional STEMI specialty program. At the time, 3 facilities were selected for initial STEMI receiving center designation based on their track record of experience, their cardiac cath lab volume, and their geographical location within the region, which at the time included 5 Northern California counties. In 2010, we expanded to 10 counties and added an additional 3 designated STEMI centers. Our regional STEMI centers are well distributed through the region, which means that there's very few populous areas that aren't within our 45-minute catchment area for direct transport to a PCI capable center. So from 2009 through 2019, we collected regional trauma data through an Excel spreadsheet. We provided the STEMI centers with a list of all the EMS reported STEMIs, which we acquired through our PCR program, which is ImageTrend. The report was to be completed and returned to us by the 15th of each month for the preceding month and was required to include all walk-in STEMI patients, as well as transfers, and then all of the EMS reported STEMI patients. The EMS reported STEMIs were required to be included in the report, even if the final diagnosis didn't end up being STEMI. This method of data collection worked great for us for a while. However, it was very time consuming to validate and abstract to get good data out of it. When the new state STEMI regs were adopted in 2019, we made the decision to switch to a registry with the intent of improving our data integrity and also to allow for benchmarking. We started with the AHA Get With The Guidelines CAD registry in January of 2020. There have definitely been some significant challenges associated with using the registry, but we're looking at the long game, and we know that ultimately all the headaches will be worth it to drive our system improvement. When the program began back in 2009, the objectives were to designate the most appropriate hospitals in the region as STEMI centers and to establish a STEMI QI committee. Those facilities that had been involved in our quality committees in the past and who showed a commitment to participating with us to improve quality processes and outcomes were engaged in order to establish the foundation of the STEMI QI committee. One of the initial goals of the committee was to standardize how STEMI patients moved from scene to STEMI center. Catchment areas were established to transport patients most likely to benefit from a PCI center directly to those centers. Data was integral to determining where improvement was needed and to measure the impact of the initiatives the committee was working on. We already had a central registry of PCR data, and our hospital partners willingly shared their data so that the entire continuum of care could be evaluated. Our STEMI QI committee is made up of representatives from our agency, the regional EMS providers, and then designated members selected by each of our regional STEMI centers. Currently, the committee does not include representation from the STEMI referral centers. However, their participation is encouraged. Our STEMI receiving centers are responsible for communicating with the STEMI referral hospitals who transfer patients to them. And they're required to have a QI process in place to provide ongoing feedback to STEMI referral hospitals on the patients that were transferred for STEMI services. In the future, we may expand STEMI QI membership to include representatives from the STEMI referral hospitals due to the fact that most of our significant system issues are related to transfer delays and care prior to transfer. Intermittently, we utilize STEMI report cards to provide feedback to our EMS providers about patient outcomes, as well as to evaluate both the EMS care and documentation for these patients. It's been a very useful tool, and our EMS providers appreciate knowing more about the outcome of the patients that they took care of. For nearly a decade, data was collected on an Excel spreadsheet. Initially, we collected 73 data elements. In 2016, we reduced the number of data elements to 46. The hospital was responsible for entering the hospital data fields, and then we pulled the EMS data fields from our PCR registry. So getting consistent data to assure that we were comparing apples to apples was a challenge. We were never sure if we were getting all the patients that should be entered on the spreadsheet. It was largely dependent on each hospital to determine which patients they defined as a STEMI patient. The data is only as good as the data entry person and their interpretation of the data elements. So identifying and collecting missing data was time consuming. Getting relevant data out of the back end required significant abstraction time. It was prone to error. Our QI meetings are held twice a year, and we review the previous 2 quarters of data at each meeting, and it often took me a full month to abstract the data for the meeting. We had no mechanism for benchmarking, and we had to track risk-adjusted mortality using NCDR data that we collect from our hospitals. So in 2020, we began using the AHA Get With the Guidelines CAD registry. At the time, only one of our 6 STEMI centers was already using the registry. And initially, there were a number of concerns brought forward by our STEMI centers. A big area of concern was the cost of the registry. Registries are expensive, so the value added had to be considered. With the AHA, there is a cost to the hospitals as well as a cost to the LEMSA in order to access the data through the super user capabilities. So ultimately, we made the decision to include the cost of the registry in our STEMI center fees and centralized billing through our agency. I have to say the initial training rollout for the new registry was suboptimal. Some of the challenges included identifying which staff should be trained and determining the best method for doing the training. Another significant concern was the number of data elements, which would require hospitals to either assign or hire additional resources to manage the registry or to regionalize their data abstraction and reporting. Unfortunately, for those hospitals who opted for regionalization, it's resulted in a decrease in participation at the local QI level since they do not regularly attend our meetings. If some data is good, more must be better, right? We had been collecting 46 data elements prior to moving to the registry. The AHA registry had 98 data elements. So we looked at it like this. If the data is not of value to the regional STEMI system, it just means more work with no associated value. So in order to maintain commitment and engagement by our hospitals, we ultimately decided to reduce the number of required fields from 98 to 70. And we maintained only those that were essential to system surveillance. However, most of our STEMI centers do continue to enter data in all of the data fields because they use it for their internal quality processes. There were some challenges with collecting the system data we needed, using the standardized data elements that were in the registry. At the time, custom data elements either didn't exist or weren't offered. Probably the most significant challenge for us was the inability to collect data for patients who were determined to be a STEMI by our EMS providers, but ultimately were not diagnosed with a STEMI. The AHA registry is a STEMI registry, so by definition, it only includes patients with a STEMI or NSTEMI diagnosis. So we use our over triage data primarily to track trends in EKG and paramedic over triage. We review the data so that we can identify the most common reasons for over triage, and then we direct our training and education at improving EMS assessment and EKG capture procedures so that we can decrease false alerts as much as possible. With the addition of custom reporting elements at the beginning of 2021, we are currently working on solutions to assure that the registry meets the needs of not just hospital users, but also the needs of a regional EMS system. We've spent a significant amount of time retooling a system which was predominantly designed for hospital users to meet the needs of regional system surveillance. On the upside, there are a lot of great benefits to the registry. First of all, there's an easy-to-use hyperlinked data dictionary, which significantly improves data capture among all the hospitals. It allows for consistent data reporting and means less room for interpretation of what the data fields mean. From a super user standpoint, it's easy to identify which records have missing information and then correct those deficiencies before we report out on the data. It also provides a more secure platform for data exchange than emailing an Excel spreadsheet back and forth. There are multiple reporting options in the registry. I use a variety of canned reports as well as custom data download reports to get the data that I need out of the back end. Once I have my customized reports downloaded, I use them to power some Excel dashboards that I created, which gives me the ability to monitor the system at a glance. So this means that issues in the data are identified sooner, which allows us to be more responsive to problem areas. The system also allows for multiple benchmarking options. So we can now benchmark our system against other California hospitals, national hospitals, STEMI receiving centers, and about 20 other benchmarks that are available. The registry does also report risk-adjusted mortality. I will say there are some challenges in the reporting of risk-adjusted mortality in the registry, but it does provide us with a consistent, timely reporting tool for this measure. So I wanted to show you a few of the dashboards that I maintain utilizing the data we extract from the registry. This is our EMS dashboard, which allows me to monitor our EMS metrics, including scene time, time to 12 lead, and time to STEMI alert. The report also shows me changes in the system at a quick glance. I can look at our over and under triage rates, respond to outliers very quickly by just drilling down on the data, and then communicating with our EMS providers sooner rather than later if I identify an issue. The dashboard also helps me to see where I might want to focus an audit. For instance, when I look at this dashboard, I see that air EMS scene times versus ground EMS scene times, there's a significant difference. The dashboard shows that our air providers take almost 40% longer on scene than our ground providers do. So if there's anything noteworthy in my findings or in my audit, then these would be taken to our STEMI committee meeting for further discussion and then action planning if it's warranted. This is our STEMI referral hospital dashboard. For our transferring hospitals, we monitor dwell time at the sending facility prior to transfer. We look at door to 12 lead times, and then whether or not patients are receiving thrombolytics prior to transfer. We have a large geographical area, and transfers are challenging for all of our specialty patients due to limited CCT resources. Monitoring the data has made it easier to identify the sending facilities that do have prolonged dwell times prior to transfer, and then we engage the STEMI receiving centers and working with them to address those challenges. Again, following the AHA guidelines, we monitor patients receiving thrombolytics prior to transfer. And if it's not possible to get a patient to PCI in less than 120 minutes, we look at why thrombolytics were not given. For some of our sending hospitals, it's practically impossible to get a transport resource and get the patient to a PCI capable center within 120 minutes. Transfer patients are a big challenge in our system. So we do continue to focus a significant amount of time and attention on trying to address this. This is our STEMI receiving center dashboard. Again, utilizing the dashboard, current data can be imported by using a quick customized report, and then issues can be visually identified very quickly. Some of the things we're currently focusing on in our system include ED dwell time. If pre-arrival EMS STEMI alerts are of benefit, then we should be seeing ED dwell times for EMS patients notably shorter than ED dwell times for our walk-in patients. When we see a facility without a time advantage for EMS patients, we delve deeper in to take a look at what their internal processes are for EMS activation. Using a dashboard also makes it easy to identify multiple issues that might be related. And looking at this dashboard, I can tell you that the hospital with the highest risk-adjusted mortality also has the lowest patient volume. They also have the longest ED dwell time for EMS patients and the longest arrival to PCI time for walk-in patients. So I can correlate the low percentage of EMS pre-arrival cath lab activations to the ED dwell time, which may explain why EMS patients spend more time in the ED than the walk-in patients do. Prior to using the registry, I did try to use dashboards with our spreadsheet data, but the time it took to clean the incoming data made it nearly impossible to use the dashboards effectively. Lastly, this is an example of the STEMI receiving center quality reports we recently began sending. We send these to our STEMI receiving centers as a tool to help keep track and have timely reporting of their performance against our system goals that we've established. In the past, our STEMI meetings were the first time the hospitals were seeing their data for the previous 6 months, and this limited their ability to speak to the specifics of what that data meant. So by providing the data to our hospital partners on a more regular basis, we hope to have more informed discussions at our meetings with a higher expectation that our committee partners will come prepared to discuss their interpretations of the data and what their initiatives are to drive performance improvement at their facility. So at the end of the day, the system's only as good as the stakeholders who participate in it. Without a collaborative team who are willing to participate and engage actively in the quality process, you're limited in your ability to make changes that actually improve performance. We look at our role as the LEMSA as that of a facilitator. We're here to present the big picture, share system data from first medical contact to hospital discharge, and to focus the lens on system issues that actually impact patient care. So here are the things I think we're doing well. We include both contract and policy language to clearly identify what we expect of our hospitals and EMS provider partners. We have good participation at our QI meetings, and we frequently share best practices among the group. We communicate regularly with our partners, and we continue to find meaningful ways to utilize the data to drive performance initiatives. There are always opportunities for improvement, and we seek those out. We have a good team, and we appreciate the commitment of our regional hospitals and EMS providers in maximizing system improvement.